This is SG2 Perspectives, a weekly conversation between the SG2 intelligence team and industry thought leaders about the biggest trends in healthcare. We're happy you joined us today. Enjoy the episode.
Freestanding EDs are not innately good or bad. Is the system using the freestanding ED in a broader strategy? Are they using it to decant, create more access for patients? Are they just building a freestanding ED for the sake of building a freestanding ED and fitting in with everyone else who's doing it?
Welcome to SG2 Perspectives. I'm your host, Trevor DaRin. We're going to talk today about freestanding EDs and microhospitals. I have Ivy Zhu and Tori Richie back on the podcast. Thanks so much for being here as always. Ivy, we talk urgent care, we talk freestanding EDs, hybrids. I live in Colorado, Denver Metro. There's lots and lots of hybrids. How do we differentiate between those? How do they fill different strategic needs for health systems?
Everyone's asking these questions these days. We start off with urgent care. It's the cheaper and easier way to get care when patients don't want to go to the primary care, but it is not for when you need something that is high acuity. Patients go to urgent care for low acuity issues and for convenience. And many health systems utilize urgent cares to help decant the low acuity patients outside of the ED. Freestanding EDs, the new hot topic. Freestanding EDs function basically the same as an ED, but it's physically not attached to a hospital. It is operated almost the same as a ED, and the physicians are all emergency trained.
Typically, it doesn't provide the full suite of services that an ED potentially can because of its off-site nature. You're probably not going to the freestanding ED for truly life-threatening emergencies. This would be your intermediary between that urgent care and the traditional ED setting.
In the micro-hospital model, especially when they're operated through a partnership with a third-party operator, that model is no physicians on site. There's a virtual connection and there's APPs and MPs on site in person. Is that model carrying over to freestanding EDs too?
We've heard about that model being carried out more in the hybrid, where you would have APPs serving on the urgent care side while the physicians are carved out for ED. I'm not sure about freestanding ED if there's no physician model.
There are physicians because it is more high acuity, but you get the best of both worlds, which Tori has hinted about. The hybrid model is the best of both worlds. You get an urgent care and an ED within the same space. When the patient gets there, they are triaged who either get urgent care or emergency care. This is helpful for both the patient and the provider because resources are utilized properly and patients are able to save money and time.
In this particular model, that triage protocol is often APP-led as well. Systems are most efficiently deploying their physician work staff. It really is carving out that physician capacity for those most complex cases, which are then filtered and triaged to the emergency department itself.
Some of it's time of day. There's a time where the urgent care cuts off and then everything's ED, right?
Yeah, exactly.
Is that dictated by the state or the site?
I believe it's dictated by the site.
Yes, it's more so convenience and operation models.
We talk a lot about your urgent care strategy as being a way to open up access, making sure that you are operating those sites of care outside of just traditional business hours so that people are able to adequately receive the healthcare services that they need, even if you're not able to staff 24/7.
So in the micro-hospital world, the standard is try to be within 20 miles of the tertiary hub that you want the patients to go to. There's going to be a fair number of transfers because they're going to want to keep a more select set of DRGs, and being within 20 miles, it's a round number, but it's been a rule of thumb, especially for those systems that have multiple micro-hospitals. Is there a similar rule for freestanding EDs?
Definitely, because of that acuity consideration. If you have a patient that presents with a stroke, you want to make sure that you're able to transport them in a timely and efficient manner to that hospital setting to be able to manage their condition and help ensure positive outcomes as much as you possibly can.
My opinion on microhospitals has shifted over time because at first they were, what's a market we want to be in? Great. This is a new toehold in that market. And it doesn't really matter how connected it is into the rest of our system of care. It's branded that way and it's a new growth channel into the growing commercial segment of our market. But that shifted over time. They're much more a capacity release valve now. There's still considerations about market selection and where do you want to be, but it's much less a new commercial toehold, and it's much more working within the system of care and keeping patients out of the busy tertiary ED and site. My opinion of microhospitals can be pretty favorable because I see them as a low-cost, easy growth site of care. Does that mirror your opinion of freestanding EDs?
Freestanding EDs are not innately good or bad. It depends on how the system is utilizing it. Is the system using the freestanding ED in a broader strategy? Are they using it to decant, to create more access for patients? Are they just building a freestanding ED for the sake of building a freestanding ED and fitting in with everyone else who's doing it? If the system is building a freestanding ED with a strategy of increasing access, improving the wait times in their actual EDs and time to diagnosis, it's a great resource to have and improve the overall footprint and impact of the organization itself.
I agree. Both for freestanding EDs and microhospitals, it needs to be intentional and there needs to be follow through, because setting up the site, either of these sites of care in a very transactional nature, we're looking to improve our catchment in this area. That might work for you in the short term, but you're not building long-term loyalty or penetration within those communities if you're not then able to back up that resource with any of the downstream services that those patients are likely to require. Sure, it's great as a first point of access for your healthcare system, but if you're not able to efficiently connect those patients with downstream procedural activity, diagnostic and imaging capabilities, chronic disease management, it begins to fall flat and you're going to see those patients defect to other providers over time.
Is this a low-cost site that we think systems are going to invest in to maintain access for Medicaid patients and uninsured patients, but we think in general benefits are going to be worse because it's lower cost from the system perspective? And then the patterns that we know and have seen in the past where as patients' level of insurance coverage declines, they get care less and less, and then they show up in the ED with an exacerbated condition. Is this a way to offset that and best serve this population?
It depends whether it's a freestanding ED or a hybrid ED. Offering access points to communities that are under or uninsured is going to be important because of the freestanding ED's ability to serve as a release valve for a traditional emergency department. It could be a very compelling way to help ensure that you're retaining capacity and resources for those truly emergency cases as individuals are increasingly leveraging ED-esque access points as the front door because they don't have any other means to obtain medical care.
I can't help but feel like a staffing model where there's not a physician on site and there's virtual backup for the emergency docs and maybe leveraging tele-ICU, telehospitalists, try and make the most efficient model possible. From the whole system perspective, it's better to treat a patient who can't pay in a setting like that rather than in your most expensive tertiary hub.
We don't want to see is these patients just continuing to show up at the freestanding ED or hybrid ED. Even if you're not able to help ensure complete care continuity, what are resources within the community that you're able to partner with to help these patients have access to pharmaceuticals? They do have access to healthy foods. They do have access to nutrition counseling. Anything that you can do to help mitigate repeat utilization and help manage those chronic conditions they're most likely to have mitigated at that freestanding ED.
And you don't want to create two health systems, one that's all virtual interactions for poor patients and then in-person system for patients who can pay. That's not the goal, but if we're looking at a situation where payer mix is going to continue to be a big struggle, maybe you need efficient options located in markets where you know that's going to put the most strain on it. Looking ahead, what do future models of these services going to look like?
Future of freestanding EDs, there will definitely be more use of virtual care, but also there will be more use of virtual delegation. In the new consumers data we got from last year, patients want to be a lot more engaged where they want to be engaged in their care, and the longitude view of managing their own care is very important to them. The future of freestanding EDs is not just in the moment that care you get in the facility, but also being able to chat with nurse practitioner or someone. Do I need to come in? Is this needed? More longitude and also preventative care. It's good for both ends because you don't want to clog your freestanding EDs on top of your EDs.
I was on a call with a member and I loved the soundbite that they gave me, which was when you think about the most hated, dreaded task of adulthood, and that's going to the DMV, it's miserable. You know that it's not going to be an enjoyable experience, but you at least know where you stand in the line. You know how many people are ahead of you. You know generally what the wait time is going to be. If you're able to provide that amount of clarity and transparency in the DMV, how can we start to reimagine how it is that we're delivering care and transparency in the emergency department and related facilities? How do you scale that digital infrastructure to help increase that transparency and improve the patient experience? So ultimately, you're able to improve overall patient satisfaction and increase loyalty to your system.
The future of microhospitals could look pretty different than the footprint today because many of the DRGs that are most commonly treated, especially for the short inpatient stays at microhospitals, are the things that we anticipate are likely to shift to home. It's going to be market to market, where there's infrastructure for home care. The mix of what can show up and stay at a microhospital, can it shift to be that much higher acuity? Many systems are building the space to be flexible, maybe more patient visits rooms in the future. Maybe it's more of a glorified observation unit. There's going to be more pressure from payers to use observation status. Better to do that in a low-cost setting. The model's working well today, but I'm not sure that 5 years from now it's going to look the same. There's probably some big pieces around site neutrality that could also change the way systems use these sites.
There's a lot of pressure and focus from a payer side on how you shift low length of stay patients out of the traditional inpatient care setting. Whether that's to a microhospital or to an observation unit, that pressure is only continuing to mount. It's going to affect medical patients more so than surgical, especially in the near term, but something that health systems need to be considering and take a more proactive approach to how they're going to manage those impacts instead of just waiting for the proverbial hammer to come down on them one day.
Every payer is looking at Medicare spend going up and medical admissions, the discharge of those admissions to skilled nursing, denying those admissions and making them stay in observation care. I mean, these are all tools and tricks and tactics we've seen for a long time. Yes, there's going to be legislation that fights against it. The pendulum will keep swinging back and forth. Systems probably have to be prepared for how do we treat these patients most efficiently, because it's definitely never going to go away. You're right on, Tori.
I've really enjoyed how frequently we've received questions on this topic, because that is showing health systems are getting creative with how it is that they're redesigning and reapproaching their care continuum. I would encourage health systems to continue with that creativity, continue to workshop how it is that you're going to release that pressure valve off of your main campuses and what are the new and novel ways that you're going to embed yourself within the community. Be intentional about it. Ensure that you have the follow through. You are following up with your patients and connecting them in a very efficient manner to those downstream services that they need to remain healthy and not return to those emergency settings with any real frequency.
One of the emerging models that we've been seeing is specialty urgent care, like orthopedic urgent care, behavioral health urgent care. That has been a great way for health systems to focus on a specific service line and address those specific patient populations outside of the regular urgent care space and improve patient throughput and the quality of care they're receiving.
It's usually the other systems in a market when someone else opens one saying, what is this thing going to do? What's it going to be? The growth of ambulatory surgery centers and where those sites can be effective has people a little nervous about the microhospital model, because ASCs can do great across the street from a competitor's hospital. Because face it, the patient's pathway to get there, they're going to visit in the specialist's office, which it's efficient. They get really clear communication. Here's exactly what you do when you show up to get in. And the fact that it's across from a competitor's hospital doesn't really change the patient's journey. But going to either a freestanding ED or a microhospital right across from a competitor's site doesn't make any sense. A bigger, more tertiary hub is always going to get the EMS calls and patient walk-ins. Some of what we've learned about site location and microhospitals, they work better, further distributed from competitors. Thanks so much for joining me on SG2 Perspectives. You guys are great, and thanks for sharing your insights. Thanks for listening to this episode of SG2 Perspectives. Please don't hesitate to reach out to SG2 if you have questions or suggestions for future episodes.